Dr. David MATINO is an associate professor of medicine at the Division of Hematology and Thromboembolism at McMaster University in Hamilton. He is the co-director of the Adult Bleeding Disorders Program at McMaster. Dr. Matino's research focuses on hemophilia A and B, novel therapies for bleeding disorders, and the pharmacokinetics of clotting factor concentrates. He is an active clinical trial investigator and involved in numerous studies on thrombosis and hemostasis, with a particular emphasis on emerging therapies for hemophilia, including gene therapy, gene editing, factor VIII mimetic molecules, and coagulation rebalancing agents. And we thought he would be the perfect person to come talk to us about new frontiers in hemophilia treatment, because we've made a lot of progress in hemophilia over the years, and our options have literally skyrocketed. So welcome, Dr. MATINO.
Okay. Thank you for the introduction. Very happy to be here with you today. So in the next 25 minutes or so, we will review the novel therapies for hemophilia, what's new, and how to choose among all of these new options, probably. So, these are my disclosures. We all know that prophylaxis is the standard of care. We want to prevent all bleeds at all time and make sure that all of our patients are safe and we can avoid long-term consequences of bleeding, especially musculoskeletal complications of recurrent muscle bleeds and joint bleeds. This figure represents like normal hemostasis and how it's balanced and controlled by multiple pathways. For prophylaxis, we have traditionally targeted the replacement of the missing protein. So factor VIII is missing, we give back factor VIII. Factor IX is missing, we give back factor IX, which is very effective and very and can be very safe, very effective, and we know that it works very well. However, there are a number of limitations to this approach. In this representation of the coagulation cascade, you see a number of other molecules. There are not just procoagulant molecules, but there are also inhibitors of coagulation. There are natural anticoagulants. And that are indicated by these other yellow arrows there. And so the new approaches to prophylaxis in hemophilia have targeted these other molecules, the tissue factor pathway inhibitor, antithrombin, protein C, protein S, and on the right side of the screen you see, of course, the bispecific antibodies that are molecules that mimic the factor VIII activity, and we know very well that emicizumab is the first one of those. Now, so we moved from this environment to this, which is a list that is not complete, and I cheated because I also grouped a lot of new stuff into categories, but just to show you that there is a lot going on, and we will not be able to talk about all of these new therapies, but we will focus on 4 molecules, or a group of molecules or approaches that are closer or are already in use in some countries, maybe not in Canada yet, but are already standard of care in other countries. Well, the first one is Altuvio, because I guess you all heard that Health Canada has approved it, and we expect that it will be available in the coming months. It's a factor VIII molecule that has been modified to have a very extended half-life, but in the end, once it's activated by thrombin, it's released a naive factor VIII molecule. So its mechanism of action is exactly as the standard half-life or extended half-life product that we are already using. However, the extension of the half-life is impressive. This molecule has been a revolution because the half-life in adults is about 40 hours or more than 40 hours. And this was reflected into the efficacy profile of this drug. These are the results of the phase 3 clinical trial, the reduction in annualized bleeding rate compared to the previous factor VIII therapies, 77%, and the patients that continued into the study, in the extension phase of the study, maintained an extremely low annualized bleeding rate, well below 1, and that there was a very high proportion of patients that had 0 bleeds throughout the extension study. So incredibly effective. Now, a few considerations about Altuvio. Very, familiar, very well-known mechanism of action. It's effective, it's safe. We've been using factor VIII for decades. Can maintain factor VIII levels high for very long, normal or near normal for the most part of the week with a once-a-week administration. And it's the same medication for prophylaxis and breakthrough bleeds, which is convenient. Of course, there are some limitations in using this molecule. Still, it's an intravenous administration, cannot be used in the presence of inhibitors, and there is the potential risk for inhibitor development. We expect it to be similar to other factor VIII products, but still. The other group of molecules I wanted to talk about is the factor VIII mimetics. Of course, emicizumab, Hemlibra, you all know about it. It's a bispecific antibody that links factor 9A to factor 10, can be used with and without inhibitors, very long half-life. It's been shown that it's very safe, very effective, can be given once a week, once every 2 weeks, once a month. And as you can see in the figure below, once you have received a loading dose of this product, it's steady in the plasma, and the effectiveness of this molecule is really good for the vast majority of patients. And in fact, even in our own hemophilia registry, we know that patients that have switched or are using Hemlibra have an annualized bleeding rate of less than 1. There is a proportion that is still bleed a little bit more, about 30% of them, but the ABR is still very low, about between 1 and 2. So we know that from non-human primate studies and in vitro modeling, this product is likely giving a factor VIII equivalence about 10 to 20%, and there are still breakthrough bleeds sometimes, and for some type of surgeries, we still need to use factor VIII, so it's not completely restoring hemostasis. So this new generation of factor VIII mimetics want to kind of overcome the limitations of Hemlibra. One of the two molecules that I will talk about today is MyMate. This has been developed by Novo Nordisk. It's a bispecific antibody. Mechanism of action is the same as Hemlibra. It's been engineered to preferentially localize to the phospholipid membrane to avoid off-target effects, has an enhanced activity resulting in about 15-fold higher potency compared to an emicizumab-like compound. And in vitro, it does normalize thrombin generation. Also, as an additional bonus, has a very low volume of administration. It's an exceptionally well-designed device or auto-injector, so it avoids sometimes the large volume issues that some patients may experience with Hemlibra for the larger weight categories. The clinical data on the efficacy of this product are not out yet, but last year was presented this interim analysis. It seems that the prophylaxis with MyMate is superior to clotting factor concentrate prophylaxis. And if you look at the right side of the slide, you see that a very high proportion of patients on MyMate was bleed-free during the clinical trial. If the in vitro correction of thrombin generation to 100% factor VIII equivalency is also true in vivo, we don't know yet, of course. I don't know if this trial will tell us, but still, this is kind of the aim, to have normal hemostasis. And similarly, NXT007 is another bispecific antibody. This one is being developed by Roche Chugai on the backbone of emicizumab, basically. It's been optimized to have higher potency, better half-life, and restore completely thrombin generation as to the level of 100% factor VIII. There is no clinical data yet available for the phase 1/2 trial. However, this study is ongoing. Patients are doing very well. And in vitro thrombin generation data also show, as for MyMate, that there is normalization of the thrombin generation with very low concentration of this molecule. The NXT007 is the blue line that you see there. These are two different triggers using this assay, and in both, with fairly low concentration, you have a normalization or equivalent to 100% factor VIII activity. Again, we don't know if this really will reflect in in vivo factor VIII 100% equivalence, but still, the in vitro and preliminary results are promising. So some consideration about the novel factor VIII mimetics. Promising preliminary data. Familiar mechanism of action is similar to emicizumab. It's given sub-Q, potentially could restore normal hemostasis. Infrequent administration, because it can be given once a month, and in the case of NXT007, possibly could be every 2 months. If you look at the pharmacokinetic data in healthy volunteers, it seems that once every 2 months administration might be possible. So we don't know, let's see, but it could be. And of course, they are effective even in the presence of factor VIII inhibitors. For now, we don't really know what's the real factor VIII equivalence. It's likely to be superior to emicizumab, but we don't know. It might be that we will still require factor VIII or bypassing agents for breakthrough bleeds. It's not yet clear what's the rate of anti-drug antibodies and if these anti-drug antibodies will have a pharmacodynamic effect or not. And of course, we need 4 more safety data. Switching to another group of therapies, some rebalancing agents. I was showing you this figure before and the inhibitory pathways. And in particular, there are 2, the tissue factor pathway inhibitor and the antithrombin that have been targeted as a new possible way to achieve hemostasis in hemophilia. Marstacimab and concizumab are monoclonal antibodies that targets TFPI, and fitusiran, a small interference RNA that targets antithrombin, 2 natural anticoagulants. These have been recently approved by FDA, by EMA, but luckily, these are approved for different indications, so nobody fights. Olimo is for patients with hemophilia A and B with inhibitors, and Impavsi or marstacimab for hemophilia A and B without inhibitors. I expect that this will change over time, of course, but let's see. These are the phase 3 data for the marstacimab trial that I presented here just a couple of months ago. This is the main phase of the study showing the superiority of marstacimab over previous prophylaxis with factor concentrates, and these are the extension phase of the study data that show a continuous trend towards some improvement over time with marstacimab. For concizumab, this is a table taken from the publication in the New England a year and a half ago for the patients with inhibitors. And if you look at the first line, you see the group of patients treated with concizumab. The mean ABR was 1.7 compared to the patients that were on demand with no prophylaxis. Patients with inhibitors was 11.8. So it was shown that it was superior to over no prophylaxis, as we all were expecting in this setting. Okay, just want to briefly mention that during the course of concizumab trial, there have been, I believe, 3 thrombotic events, and there was a pause, and there was some guidance that has been implemented. And to treat with the minimum effective dose of factor concentrate for breakthrough bleeds, and also to measure once, or maybe twice in some cases, the concentration of concizumab or Olhemo and adjust the therapy. So at 4 weeks after starting the treatment, there is 1 measurement, and then the dose of concizumab can be adjusted based on the amount of concizumab in the plasma. So these are the 2 compared. They are similar. They are both monoclonal antibodies targeting TFPI. There is a difference there that you can see that one product, marstacimab, is given once weekly. The other one is given once daily. For marstacimab, there is a fixed dose that can be doubled if clinically indicated, which means that if the patients experience more than 2 bleeds within 6 months interval. And for concizumab, there is the measurement of the antibody and then the dose adjustment. There's another rebalancing agent that has been recently approved by FDA. It's fitusiran. I won't even try to pronounce the commercial name, Kfitlia. I don't know if someone from Sanofi is here today that can tell us how this is pronounced. But anyways, I will call it fitusiran. I don't know who picks, who chooses these names. It's weird. I mean, I'm clearly not English speaking, but it's been approved with a companion diagnostic test for testing antithrombin, because as I mentioned before, this is targeting antithrombin. And this has been implemented. It's important to know that we need to measure antithrombin also because during the phase 3 trials, the initial dose was higher, was 80 milligram, and there was a very strong reduction of antithrombin. It was very effective. There was a very strong reduction in the annualized bleeding rate. However, this was associated with mean levels of antithrombin about 10%, which is very low. And there have been 4 thrombotic events. These were associated with very low antithrombin and an additional factor that was given at the same time. So there has been some risk mitigation that has been developed, and a revised dose and dose regimen targeting a higher level of antithrombin, 15 to 35%, has been implemented. This is achievable. 94% of the patients can just receive one dose adjustment to achieve 15% to 35% of antithrombin, so it's not difficult to do, but it's necessary to measure antithrombin. The incidence rate of thrombotic events after this guidance has been implemented is basically went down to basically the same number, the same incidence rate of the general hemophilia population. On the other side, though, the ABR increased a bit, and as we were expecting, because there is a very clear relationship between the median ABR and the antithrombin level. The lower the antithrombin, the better the bleed protection. So it's needed to find a sweet spot for each patient to achieve good protection and also good safety. So it's good that we are able to measure, but it's also mandatory that we measure antithrombin if we use this agent. And just a couple of words about thrombotic events. So all of the rebalancing therapies at some point had, the trials, we had seen some thrombotic events. These are rare events, are not common, and most of the patients had a thrombotic event at other risk factors. For fitusiran and concizumab, some risk mitigation strategy has been implemented. For marstacimab, there was only one thrombotic event, and it's still under investigation. It's not clear yet what was the cause, if there was one, and so there's no guidance for marstacimab yet. But overall, these are not common events, and the safety and benefit profile, the ratio between risk and benefits is generally favorable. So, in general, rebalancing agents, it's good that can be used for both hemophilia A and B, and in theory, with and without inhibitors. It doesn't matter. Different mechanism of action and can be used for different type of patients, can be personalized to some extent. It's effective, it's safe, I would say for the most part. Can be given sub-Q up to every 2 months. Fitusiran can be given up to every 2 months if the antithrombin levels allow. And possibly we can use it also for other bleeding disorders. There are some questions, of course. It's a novel mechanism of action. Sometimes for some of this drug, we need to adjust the dose and measure drug level. There may be some safety concern, thrombosis. There is an antidote for fitusiran. We can give back antithrombin and restore normal or abnormal coagulation, if you wish, in our patient, even though we don't know if this is really necessary or not at this point. And it's unclear what's the factor 8 or factor 9 equivalence. Is it 20? Is it 30? Is it 15? Someone say 20, other people say 40%. We don't know yet. It's probably too early to say. Last category is gene therapy. I couldn't include all of the new therapies in this category, so I have to just select the 2 that I think are today most relevant because are approved or in use already. and it's Hemgenix and Roctavian. And we know that even in Canada, we expect that we will be able to use Hemgenix soon. So talking about Hemgenix, I will not tell you much today about this gene therapy. Tomorrow morning, there is this symposium that it will focus on like a lot of details about the results of these clinical trials and long-term data. But here are the results of the phase 3 study that shows up to 18 months, the factor IX levels is stable in the majority of patients. There was a very significant reduction in the annualized bleeding rate for all the bleeding episodes and a very significant reduction in the consumption of factor IX. And 4 years after gene therapy, still 98% of participants had factor IX activity level above 5%. This is a modeling study, but still it gives you an idea of the durability of the factor IX therapy with Hemgenix. At 25 years, it's predicted the majority of the patients will still have factor IX activity above 2%. For factor VIII, the situation is a bit different. The levels, the mean levels and the durability are a bit lower. There's some concern that it might not last as long as factor IX. However, if you look at the results of the Roctavian study, you see that at 3 years, you have a fairly large amount of patients that have factor VIII levels above 5% at 3 years after infusion. And this is another way to visualize that. 92% of patients remained off regular prophylaxis after 3 years. And at 7 years for the patients that participated in the phase 1/2 study, still there is a drop, but it's kind of like a flat line at the lower factor VIII level. So it's not that it goes to 0, but probably won't be as good as the factor IX gene therapy. So a few considerations also for this one. It's a single infusion, it's a cure, it's effective, has a good safety profile. There are some questions, of course, about it. We will not be able to repeat AAV-based therapy for now, at least. Once it's given, it's given. No other AAV-based therapy will we will be able to give it to the patients that already receive it. There are some questions about durability. There's a variable amount of levels of factor VIII or factor IX achieved in the studies. It may require temporary therapy with steroids to prevent loss of the factor activity. There is the possibility of inhibitor development, the potential for supratherapeutic levels of factor VIII or factor IX, and the theoretical risk of neoplasm, even though so far there's been no real connection in humans with cancer and gene therapy with AAV. So how to choose between all of these? So for the last 30 seconds of my presentation, I will show you, I'm well over time, but I will show you this figure that I have spent many hours to do. So, okay? So what can we do to choose between all these categories or agents, okay? So I put together the exclusion criteria or the other characteristics of patients that can or cannot use this product. And I got this, okay? Ready? 1, 2, 3. Voila. The slide is available if you want to grab it for discussion with your treaters or your patient. Thank you. So I tried to put together in a table, what are, the reason to use one or another product or another category of products. It takes a long time, and it would take at least another hour of discussion to get through this, so I will not do that. But in this table, I have summarized some of the main characteristics and main reason to use one or another product if they were all available together today. Of course, this is just a limited amount of information just only for the rebalancing therapies. We should discuss this for an hour to understand really the differences and why to use one or another. But this was my last slide, and I thank you all for your attention.
Are there any questions? Are there any questions for Dr. Matino?
My diagram was very clear.
That was the best.
The diagram is perfect, David. Thank you. So with the MyMate and the next 007, I love 007. I mean, how could you do better than that? But, I mean, factor VIII has this tight control. It's this evanescent molecule, activated factor VIII, and it's quickly inactivated by activated protein C, and this whole mechanism of thrombomodulin and all of that to control factor VIII, because 8A is dangerous stuff. So if we have 100% factor VIII, aren't they just going to clot?
Well, that's an excellent question. And I don't think we have really an answer today, but yes, of course, there is a theoretical risk. And in fact, in the NXT-007 trial, there was an exclusion criteria for, well, risk factor for thrombosis, but also the patients had to be screened for thrombophilia. So we had to screen our patients just as a safety measure. Also, if you look at the data in non-human primates, it shows that the ternary complex, it's really much tighter than the one that is comprises of the imicizumab at factor 9, factor 10. And at some point, if you increase the dose too much, actually you go into a risk of having a hemorrhagic disease because of how tight is the complex and cannot be disassembled. So yeah, it's an interesting molecule. I think that there's a lot that we don't know. And as you say, the regulation might be, of course, like different in vivo.
Thank you.